So the question is, how do you identify first, second and third degree heart blocks on an ECG? Normally the distance between the start of the P wave and the start of the QRS, that is the PR interval, is less than 5 small squares, which is less than 0.2 of a second. In first degree heart block, this distance is longer. Not in itself a problem, but you should think of an underlying cause like drugs that affect the AV node or inferior ischemia. Also, it can just be normal. There are two types of second degree heart block, Mobitz type 1, also known as Wenckebach, and Mobitz type 2. In Mobitz type 1, there's a gradual increase in the PR interval, then a drop beat. This sequence may occur after 2, 3, 4, or even more conductor beats until 1 is dropped. Mobitz type 1 is not uncommonly seen after an inferior infarct. It may also occur due to drugs that affect the AV node. Most patients are asymptomatic and don't require specific treatment in the emergency department. In Mobitz type 2, there is also intermittent non-conduction of the P wave, but unlike Mobitz type 1, you don't get progressive prolongation of the PR interval. Usually each patient has consistent non-conduction of the P wave, like 2 P waves occur before one gets conducted, or 3, or 4, or 5. This is usually caused by structural damage to the conducting system like infarction, fibrosis, or inflammation. These patients may present very bradycardic and hypotensive and require transcutaneous pacing in the emergency department before going to a permanent pacemaker. Finally, third degree heart block. Here there is complete dissociation between the atria and the ventricles. The P waves are being created but not conducted to the ventricles through the AV node. The ventricles are using their intrinsic escape rhythm to survive, and this can mean a pretty slow heart rate. Essentially, these patients will need support in the ED, usually with transcutaneous pacing, and then onto an emergent permanent pacemaker. Okay, done.